Hello, everyone. I'm Milos. I woke up one day in a psychiatry because of drug addiction and abuse. This is Jan. I met him during my rehabilitation, well, online because of COVID. He interviewed me believing digital tools can improve the standard of care for drug addiction and abuse. I shared that vision, so we started collaborating together.
In Germany alone, more than 4.5 million people suffer from drug addiction and abuse. That's more than the population of Berlin, which is where we're from. Yet there are only 360,000 cases of support each year. So that's a huge deficit in care. However, 66% of those who do actually get care need multiple interventions. So what does that mean exactly? It's complicated, but in the end, it means that 2 out of 3 stay sick after treatment, which is definitely not sufficient. We want to change that, and we have identified the key metric in changing that, which is reducing relapses.
So reducing relapses actually means better care for drug users to achieve abstinence. This is seen by experts as significant, relevant, and innovative. Quit smarter for patients and care providers means that we have 2 value propositions for patients and care providers. And that's us, Leav, Quit Smarter.
Exactly. So, all right, quick survey here. Please raise your hand if you've ever smoked weed. Not so shy, not so shy. Many people I see. All right, yeah, mostly young people. And yeah, also in treatment, more than half of the people in treatment are younger than 24 years. And those people use phones for everything, also for ordering drugs. For example, via Telegram Messenger, you probably know that. And so that's why we want to pick up the people there with digital solutions, text-based via Telegram. We offer reflection for first interventions in counseling, text-based via Telegram, and then going from there, we will iterate with them first over an app, then to a whole ecosystem of solutions.
So that means we're bridging elements for an improved patient journey, integrating treatment elements for customization and advice, killing waiting or untreated time, and with intervention modules, creating a communication and care system that challenges the key phenomena that is currently not treated at all: cravings, providing digital tools in key dropout moments just in time before potential relapses. All this together to reduce relapses.
So, reducing relapses. We've identified to do that validation metrics. So what else can we prove? You can see that the dropout rate out of therapy has to be lowered. Finishing rate has to be improved, and abstinence rate long-term also needs to be improved. And from a caretaker's perspective, this means we want to reduce chronic diseases for addicts. That's our vision from Leav. So, coming to the steps ahead of us on the journey. So, we are developing a business model, mainly focused on care providers and institutions. We had the opportunity to talk during this bootcamp in the first week in Lisbon with people from the Portuguese government and from a treatment service, which really helped us a lot. But obviously, we also want to focus on consumers themselves if they're not in professional therapy yet. For example, with DIGA, which is German digital medicine, but also self-pay packages. And then also, we have digital competition scattered around the globe. However, none of them really focus on relapses. So this is a competitive advantage that we have. And also, we want to integrate the whole system of all caretakers.
So our short-term goals are iterating our MVP, extending our team, and receiving funding. Our key performance indicator for proof of concept in Germany, which is where we're from, is user desirability, healthcare provider adoption, business model viability, and tech feasibility. So with our key partner, Startup Incubator Berlin, we're looking forward to securing funding at the end of this year. With our other key partner, Patient Innovation, we aim to continue to validate our concept. And with our key partners currently in Berlin, we want to continue developing our solutions.
That's us. Leav quit smarter. Thanks a lot.
Excellent. Questions? We have time for questions. Yes.
I'm not sure I understand exactly how it works. Like, if you are in the supermarket and you're buying alcohol, then it has like a notification or something?
Not necessarily, no. This is just an example picture. So it works by satisfying various needs. So Milos, can you go back to the slide showing this needs also? Perfect, we have this in the presentation. So it works by tracking. So you can track your consumption and abstinence over time. So it works via daily check-ins, where you can learn something, track your use, and also reflect with further questions that are suited to your situation. Then also there is support. So currently therapy, it's usually once or twice a week. You have to go there, it takes an hour to go there, 1 hour be there, 1 hour go back. It takes a lot of time, so also video sessions, but also peer feedback and a buddy program that we're working on. And then also interventions. This is something pretty new in the field of addiction therapy. So we are exploring machine learning and AI opportunities also to do that. But of course, these are abstract things. What we're actually trying to do is really provide a toolkit for people so that they can get a message on the phone, for example, in certain situations, via geolocation when they approach, for example, their dealer's place. This is one possibility. But also, just if they feel, okay, something's not wrong, I feel there's an emergency, or also if there's a death case in the family, there might also be extra interventions. So it's not easy, but with the whole system of addiction care, it is possible to do a real change there.
And you have to think of it from that perspective. Currently, you go to a treatment center and you just get 6 months of support. But for that, you have to wait. You might get an appointment in 2 months. So what do you do during those 2 months? With us, you could start a reflection program before that. You could talk to people who quit because they're happy to talk to you to help you because it helps them staying sober. On the other hand, we might have digital tools. So before you start consuming again, you might use one of those tools and figure out that the craving time of 15 minutes of really wanting to use might be over.
Good. Other questions?
First of all, well done and massive respect to you for doing this. I just have a question. There was something about the B2B sales subscription kind of model that you had, right? So what, if I were an institution, if I were any of your possible buyers, why would I go and pay you guys instead of going to all of those organizations that are already doing it freely, right?
Yes.
No charge at all.
Yes. Yes. So this is actually something we have to include in the communication. So our idea is, and this is what we're doing at the moment, we're working together with exactly those institutions you talk about. So they subscribe to our services as part of their IT, you know?
Yes.
So that someone who wants to, you know, go to counseling, you call someone and you're like, hey, I have issues with drugs, I want to go to counseling. They say, hey, why don't you fill out the survey from us to see what kind of consumption you do? Are you pregnant? Do you have a job? Are you stressed because of your job? Did someone die in your family? That can then adapt the whole system of the care you get, which now is impossible. So what we can do is we can make individual subscriptions to those institutions based on the kind of population they have, based on the issues they have, based on the drugs they have. Maybe also work with other institutions that deal with behavioral addiction. So this is something we think about maybe in the future to work also on, you know, work addiction or media addiction like pornography.
Good. Let's move to the next question. Yes.
So the app for consumers are free.
So this is something we're trying to figure out at the moment. Basically, we think that certain modules can be free of charge, like the reflection program, right? Certain modules like emergency intervention, where you would speak with someone who knows your profile based on our information, that we have to organize, and for that we have costs that we somehow have to cover, that would go through ideally insurances.
sense to have like a once payment?
So this is something we want to do for the business to customer, to have a pre-package to say, you know, you get this and that for this money, this and that for that, this and that for that. Yes.
So no subscription.
We try to make it subscription, so no subscription fees for users. That's why we aim for a B2C approach, DIGA, then it's reimbursed by insurance. But also the central elements, as Milos said, should be free in certain ways so that we can ensure a good quality of care for everyone.
Yeah. Because I mean, we both come from an addiction and abuse background, and we do want to support the community besides just feeding into the medical system. You know, in Germany, for instance, there is a huge system of people doing support for free. And we strongly identify with that vision as well. We don't want to be an online hospital.
All right, so next question.
So I'm assuming this is before you go to a therapy session, right?
So, you know, the patient journey in addiction treatment is very complicated, or there are different elements. So there is stationary care, psychiatry, there's ambulant care where you sleep at home and you go. And there are waiting times in between all those elements. So yes, it can be before you start. It can be between one of the two elements. It can be when you're technically healthy.
Okay, so will it, if it's like in the waiting or during a therapy session, will it be like implemented so it's, you know, incorporated with the therapy from the?
Yes, yes, that is very much our idea, you know, to work together. So this is why, you know, there is the back end for the therapeutic care providers. You know, so for instance, they know what you have done, you know, and you can talk about it.
I'll take your final question.
Do you have in mind to conduct clinical trials to prove the efficacy of this option compared to what's already done?
Can you please repeat this? I didn't get the last part.
If you have in mind to conduct clinical trials to prove the efficacy of this solution compared to the available solutions that other institutions use right now?
So yeah, we definitely do want to do clinical trials because we also need this for a CE mark or DIGA improvement. But the thing is, how is success measured in addiction treatment? In Germany, it's currently, if it doesn't get worse, it's success, which is a bit paradoxical in my opinion, and we have higher standards than that. But also, yeah, we try to make clinical trials, one control group, one group without technology. We haven't designed that yet because we also didn't finish our product yet, but we do definitely want to do that, yeah.
But however, before clinical trials, we want to work with clinics so that, for instance, in the situation that I was in, you wake up in a psychiatry and someone tells you, well, we might think, you know, you might be smoking a bit too much weed, and you're like, what do you know about it? They say, okay, why don't you check out this project? And then you get information that is made for you. You know, someone in your age group from that region where you are for the reasons you smoke, because the doctor knows all that, right? And the doctor doesn't have time to explain it to you because time is precious.
Time is precious. Thank you so much. Thank you.